Hi everyone, thanks so much for coming today. I'm Eileen O'Connor. I'm one of the co-founders and leaders of NYCD16-Indivisible, and it's our group that's hosted this event today, so we thank you very much for coming. Our health committee, headed by Judy Fletcher, there you are, okay, wanted, after speaking with Tara Herman, Deb Porter, and others, to host a forum to discuss the Medical Aid in Dying Act. All New Yorkers need access to reasonable and compassionate options for care at the end of our lives. This Medical Aid in Dying bill situates itself within that aspect of healthcare. This raises questions and issues from different perspectives for many of us, so we wanted to present an opportunity to educate ourselves, ask questions, and then move to action on both a personal and or perhaps a political one. So I want to thank Tara Herman, who's basically put this forum together. Compassion and Choices for their amazing work around this and other patient autonomy issues. Fantastic resource, and we'll point you in that direction to access that information. And our co-sponsors for helping to get the word out about this forum. Including our group, NYCD16-Indivisible, Northwest Bronx Indivisible, Indivisible Westchester, Scarsdale, Westchester District 6 and 7, Indivisible Cohope, the Westchester Black Women's Political Caucus, Indivisible Yorktown, Westpac, the League of Women Voters, both the Northeast Westchester chapter, the Newcastle chapter, Rivertowns chapter, and the Women Democrats of Westchester. So thanks to everyone for putting the word about this today. We are Facebook Live on our NYCD16 site, as well as have an active Zoom link going. So I'm not sure how many people are on the virtual calls, but we will find that out, and we will include them in our question and answer period. So Judy, our ever-present stalwart chair of our health committee, will moderate the discussion. We'll spend about 40 minutes listening to each of the speakers and then give ample time for questions and answer period. We have note cards so you can write your questions down. Did everybody get a note card to do that? If you need a note card, raise your hand and we'll bring that to you, okay? Or you can raise your hand and ask a question. So that is it, I think. And we have information over at the table there that Tara's going to talk about. And once we have the speakers finish their presentation, we're going to move that table up in front of the screen here so we can do the question and answer period, okay? All right, thanks again, everybody. Judy?
Is this a good level?
Yes.
Today's speakers are advocates for the Medical Aid in Dying bill and come from a wide variety of perspectives. This forum will also provide us with the opportunity to ask questions about the nuanced ethical concerns that may pose, as well as its practical applications. Our first speaker is Amanda Cavanaugh. She's an expert on medical aid in dying. She does government relations for Malkin and Ross, and she's an alumna of Compassionate Care and Choices.
Before we hop into medical aid in dying, I just wanted to share this quote with you from Atul Gawande, and he says, life is meaningful because it's a story, and in stories, endings matter. So before we dive into all of the details about medical aid in dying, I just want to take a moment to share that medical aid in dying is an end-of-life option. We're talking about one tool in the toolbox for doctors. We're not talking about everyone. This is not an absolute. So I just wanted to share that quote with you. In New York State, we have a number of advanced care planning documents. You can see them listed here. I won't go through them one by one. Death is inevitable. We say that all the time, but suffering does not have to be. And so when we think about what our final days look like, and we're talking about medical aid in dying, we have to talk about a full range of things. And so I wanted to mention these advanced care planning documents to you to make sure that you were aware of what options are currently here available in New York State. There are some really good resources that are free for folks to be able to use to fill out advanced care directives, the things that happen before crisis strikes, before someone has a terminal illness. So I wanted you to know where you could get these. The Attorney General in New York State has a really great resource, as well as Compassionate Choices and End of Life Choices New York. They have really easy to fill out forms to get yourself where you should be. Current end-of-life options in New York there are many things that are available. Someone could choose to use all treatments. If, say, you're facing cancer, you don't have to decide to give up, so to speak. You can take any and all treatments and interventions, or you could stop doing any and all treatments. You can voluntarily stop eating and drinking. You can choose palliative sedation, and in states where it's authorized, you can use medical aid in dying. Medical aid in dying is an option for someone who is terminally ill, who is mentally capable, who has a prognosis of 6 months or less left to live. It is something they can request from their doctor or not to choose to die peacefully. It is a medication that they take generally at their home. You have to take it at home, and it just gives the patients power at the end of their lives. It is sometimes referred to as death with dignity. Currently, medical aid in dying is available to 1 in 5 Americans. There are 10 states plus Washington, D.C. that have medical aid in dying as an option. As you can see on the screen, in the last few years, quite a few states have authorized medical aid in dying, and that is because of Brittany. Brittany Menard was a young woman who wanted to use medical aid in dying after facing a diagnosis of terminally ill brain cancer. So she moved from her home in California to access the option in the state of Oregon, where it has been legal the longest. Brittany shared her story publicly with the world. She was on the cover of People magazine, and her husband Dan continues to advocate for this option, which leads me to why I'm here today. When Brittany's story was shared, I was at home with my partner, Chrissy, who too was facing a terminal diagnosis. Unlike Brittany, we were not able to move to a state where medical aid in dying was an option. At the time, that wasn't feasible for us. So Chrissy suffered at home horribly at the end of her life. She wanted medical aid in dying. She asked her doctors for medical aid in dying, and her ending was horrible. And that's the reason why I'm here today, because for 9 years, I've been advocating alongside Dan Diaz, who's Brittany Menard's husband, as he shares what a beautiful journey Brittany had at the end of her life with going on trips with her loved ones, her mom, and Dan and her friends, really enjoying the experience of her end of life. And instead, for us, for Chrissy and I, we spent our days worrying, not taking last trips, not enjoying our days, suffering. At the end of her life, I had to give Chrissy medication every day until essentially she died, where Brittany was in control of her own medication, her own health care. So there's a stark difference. We know there's a better way, and we look forward to passing the Medical Aid in Dying Act so that no one has to suffer the way that Chrissy did. And as many other advocates, we have lost 25 advocates that used to be in this room with us, that used to be around asking for this, have died suffering since we started this campaign in 2015. And so I'm here today for them and for Chrissy. And I believe now we are going to get into the details of New York's Medical Aid in Dying Act. I'd like to turn it over to Health Committee Chair and Assembly Member Amy Paulin.
Thank you for letting me be part of this panel. Thank you for sharing your personal story. I don't know that I ever heard that, Amanda.
Can you bring your mic closer?
Yeah, can you hear me now?
Yeah.
Okay. Our bill, which we started drafting, I think, around 2014, allows medically competent, terminally ill adults, 18 and older, to request medication that will allow them to end their suffering and have a peaceful death, a death with dignity. In drafting this legislation, we were very aware that any law about life, death, and patient suffering had to have the input and support of a wide range of people. Most importantly, those who are facing a terminal illness and those who have been touched to the core by seeing someone you love die an unbearable death. When I first introduced this bill, my sister had been in remission. I wasn't even thinking about her illness. It was more a reaction to a lobbyist who I liked a lot, a friend, someone who lived locally, said, would you consider sponsoring this bill? And what I do when there's a bill I know is going to be a hard bill to get done, I talk to my staff and we talk about it. And we collectively decided that although it would be a long, hard fight, we would take it on. A little while after that, a year or so later, my sister's illness came back. And I watched my sister die of ovarian cancer. It was a painful, painful death. And because she didn't live next door, and it was Mother's Day weekend, and we had been with my mom, I missed her last moments. Her husband told me that she was screaming at the end, crying out for her sisters. That thought haunts me every day. The momentum for allowing aid in dying is growing. Aid in dying legislation has been authorized in 10 states and in an additional jurisdiction, Washington, D.C. So California, Colorado, Montana, Oregon, Vermont, Washington State, Hawaii, New Mexico, New Jersey, Maine, and as I said, Washington, D.C. all allow this. That's a lot of places. Recent polls have confirmed the shift in attitude over the past several years. When I first introduced it, including me, I had really never heard of it. And things that Oregon did back then, we just didn't, we knew they were a little bit out there, so we didn't always think that was something that was going to be applicable locally. But recent polls have shown that 77% of New Yorkers support aid in dying, including 75% of Catholics, 72% of Republicans, 67% of self-identified conservatives, and 78% of upstate residents. All those populations that you would normally think would be in opposition. 57% of physicians in the US believe medical aid in dying should be available to terminally ill patients, up from just 46% just 6 years ago. Aid in dying may not be for everyone, but it is an option, as Amanda said, and should be available to all New Yorkers. And that's why I'm committed to working with all of you and my colleagues to get this bill on the floor of the Assembly this year. Essentially, this legislation would allow terminally ill adults to request that their attending physician prescribe them medication to allow them to end their suffering and have a peaceful death. It would provide a primary physician, consulting doctors, healthcare facilities, and other witnesses with immunity from civil or criminal liability. The intent of the bill is to allow terminally ill patients to choose the time, the place, and the manner of their death, and to allow healthcare professionals to provide them with the means without incurring liability or professional disciplinary action. The specifics of the bill: the patient must be 18 years or older, have a terminal illness, A terminal illness is defined as an illness that will, within reasonable medical judgment, result in death within 6 months, whether or not the patient receives treatment. Simple advanced age or disability are not, and I say are not, sufficient to allow someone to qualify for aid in dying. There are many requirements set out in the legislation that serve as safeguards to ensure that only mentally competent terminally ill patients who ask voluntarily and without coercion for medication to end their lives can obtain the medication. Let me highlight just a few. First, the terminally ill patient must make an oral request and a written request to his or her attending physician. The written request must be signed and dated by the patient and 2 adult witnesses in the patient's presence. The bill is very specific as to who can and cannot be a witness. One of the witnesses must not be related by blood, marriage, or adoption, someone who at the time of the request is entitled to any portion of the patient's estate under a will or by operation of law, an owner, operator, or employee of the healthcare facility where the patient is receiving treatment, or, this is what they cannot be, or the patient's attending physician, consulting physician, or if applicable, the mental health professional who determines whether the patient has capacity. These witnesses must attest that to the best of their knowledge and belief, the patient has capacity, is acting voluntarily, and is not being coerced to sign the request. The form of the request and the witness declaration are all set out in the legislation. Second, the attending physician must determine that the patient has a terminal illness, has capacity, has made an informed decision, and has made the request voluntarily and without coercion. The attending physician must refer the patient to a mental health professional if the physician believes that the patient lacks capacity to make an informed decision. They must provide information and counseling regarding palliative care, inform the patient that he or she can rescind the request for medication at any time and in any manner, fulfill the medical record documentation requirements set out in the bill, which are very specific and are very detailed. In addition, a second physician, a consulting physician, must reaffirm all of the above. And I just want to stop here for a minute. There is nothing, there is no procedure, there's no medical indication that requires all of these things. And most of these things were copied from all of the other 10 states. Those 10 states changed it a little, but it's the same model. We changed it a little too, because every time there was new information out there, we tried to accommodate and actually build in more safeguards as we went along. The patient may self-administer the medication to himself or herself. No person can administer the medication to the patient. It has to be self-administered. And we've been criticized by some organizations that actually want an expansion to that. But we've held firm because, we don't believe, we want to get this passed first. And then perhaps, if other states who've had more experience feel that there needs to be an expansion, and I don't think they will because Oregon's been doing this for quite a long time, then they could come back to us. But at this point in time, we have no interest in expanding beyond a self-administered dose. There's a lot of other protections that I just want to highlight, some of which, or most of the ones that I'm going to mention, have been asked of me in one form or another. Life insurance benefits cannot be denied to the patient or his or her beneficiaries, and the sale or issuance of a life or health insurance policy or the rate charged for the policy may not be conditioned on or affected by a patient making or rescinding a request. Insurers cannot provide any information and communications made to a terminally ill patient. There's a lot of concern about coercion or persuasive coercion, so to speak. And we are absolutely adamant that insurance companies cannot do that. The sale or issuance of a professional malpractice insurance policy or the rate charged for the policy cannot be conditioned upon whether the insured does or does not participate in any action under this legislation. The health department must adopt regulations providing for the safe disposal of any unused medications. And lastly, we have built into the bill, a way to report and review the process. Thank you. Like they did in Oregon, there needs to be an annual report where this is monitored. If you look at those annual reports in Oregon, you learn that there was not coercion, despite what you might hear from others. We expect the same result, but we want to monitor it. So therefore, we put in the requirement in the bill. We've recently modified it. As I said, we're constantly learning. And we put 2 recent amendments in that were proposed by the Hospice and Palliative Care Association of New York State. And we're proud to be working collaboratively with them because we are all together trying to make sure that patients have an option at the end of their lives if they're suffering in this manner. So, I'm going to stop here, and I know there'll be questions at the end.
Next, we have Dr. Maggie Carpenter, who's going to give us a doctor's perspective.
Hello, everybody, and thank you for inviting me. I'm a family physician by trade, and in around 2013, I started doing home visits with patients. Yep. I had a number of patients. Is that better? Yeah. I found in my regular family practice that there were a lot of patients who had a hard time coming in. Somebody in their life would have to take a whole day off of work. They would need to then bring them in. And by the time they got in and waited, the hour and a half, which you do in federally qualified healthcare centers, everybody was burnt out. Nobody knew the medications. Nobody knew what was going on. So I started visiting patients at home and then started my own home visit practice. And as you can imagine, people who are more homebound have a lot more illnesses that lead towards their end of their life. And I'd always been in favor of medical aid in dying. I remember when it passed almost 30 years ago in Oregon, and was always surprised how long it was taking for it to sort of go to other states. That has been escalating. But I was always on the sidelines. I just sort of believed in this. I had patients who were asking for it. And then in 2016, yeah. As we've been saying, the medical aid in dying is allowing people who have a diagnosis of less than 6 months, if they are interested in ending their life at that time, then we can give them medications that will allow them to end their life without suffering. We're going to ask questions later. Yeah, so if you can hold off.
At the end, you can write them on a note card, or we'll bring around a mic.
Thank you. So when my father was ill with pancreatic cancer, and there were no treatments that were really good options for him, he said he decided to go on hospice and to live the next few months as well as he could. We had a lot of parties. He's convinced that his martinis, he had these little onions he made them with. He's like, I'm pretty sure it was the medical marijuana and that made me live so long. But as he was getting to the end, he knew he didn't want to suffer, and he didn't want to prolong anything. And he made me promise that I would help him. And I said I would help him. And then when it came down to the time where he said, okay, I'm done, I realized he had no pain medication. There was no way for me to do this in a way that I was not going to end up in jail. And it was the hardest few weeks of my life because it was so stressful to feel like I'd promised this for my father, but yet I couldn't really follow through on it. And we talked about voluntarily stopping eating and drinking. And the funny thing is, my dad lived to eat. So this was just, he thought, oh, that's what I'll do. And then when it came down to it, it was impossible. As a hospice physician, I was the medical director at Hudson Valley Hospice for 5 years. I have helped about 5 patients die through voluntarily stopping eating and drinking. It was hell for all of them. It was prolonged, and it was uncomfortable for them, and it was uncomfortable for their loved ones and their caregivers. They were all on hospice care, and they had to do that. I've also had a number of hospice patients ask me, can you give me something? And I've had to say, no, I can't. And it breaks my heart to not be able to do, because really what this act is about is choice. You know, I saw the protester outside, and I thought, you don't have to do it. If it's not for you, don't do it. But this is about choice. And this is not suicide, because these are people who are going to be dying anyway. It's a way of deciding the manner of your death. I can't tell you how many loved ones have said to me, my dog had a better death than my loved one. And so, you know, I have gotten off the sidelines and now am actively talking to people. I'm aware that there probably are going to be a shortage of physicians who are willing to certify patients in New York, and I have a feeling that will be my next life fight, is to try and get other physicians to stand by my side and do that. I can tell you that most physicians I talk to do believe in this, and also at hospice, even some of our spiritual pastors are in favor of it. The nurses are in favor of it. And we even talked about it as an organization. If somebody was opposed to medical aid in dying, that nobody would be forced to have to help a patient who wanted to end their life. The other thing I want to add is that a lot of times there's been some objection saying, well, who really knows how long somebody has? Well, studies have been done for 30 years in Oregon. Most people do not actually take this medication. Most of them actually never take it. It's just the insurance of knowing that they have that as an option. But then if they do take it, they really take it in the last hours to days of their life. There's a very vocal person in New York who states that, you know, he would have died years before had he, because he was interested in this and pursued it, and then had a moment of changing his mind. And his family now still argues that he would have ended his life early. But he wouldn't. Like I said, most people get the prescription and then they wait to take it until they're ready. And for many, more than half of people, they never actually take it. It's just the security of knowing that if things get really bad, you do have that option. So I'm definitely going to answer a lot of questions. I wanted to keep my comments brief.
Great. Thank you. Assemblymember Reverend Al Taylor of Assembly District 71 was not able to make it, so Amanda is going to present for him.
Hi again. So Assemblymember Al Taylor could not be here today, but recently had a piece in the Empire Report that I'm going to read and share with all of you. As I mentioned, I've been on this campaign for 9 years now. We're heading into our 9th year, and when Assemblymember Al Taylor was elected in 2018, we went to talk with him, and he said, no, this is not for me. We're not talking about this. I respect you. I love you. Keep it moving. And in 2018, 2019, 2020, all for the last few years, we have continued to see him in the hallways in Albany with advocates and had a respectful dialogue, but he didn't want to go there. He didn't want to talk about this until he did. One day during the session last year, he said, hey, are you working on that thing I don't like to talk about? And I said, yeah, I'm still working on that. Assembly member, what's up? And he said, can we talk? And so we sat down and we had a conversation with a group of advocates, and he had a change of heart. And so his piece titled, I've Learned It's Time to Pass the Medical Aid in Dying Act, I'll read for you now. Recently I had a learning experience that I don't wish on anyone. My dad was sick for several years, and like a growing number of adults across the nation, I was one of his principal caregivers. Pop spent his career as maitre d' and was accustomed to waiting on people, not being on the receiving end of care. It wasn't a position he enjoyed. His condition and his quality of life deteriorated to the point he was wrenched in agony and couldn't get out of bed. He clearly wasn't happy. "I can't live like this," he told me repeatedly and with increasing frequency. I was heartbroken. This was not my vibrant, positive, full-of-life father. He was hurting, and I was hurting for him, but there was nothing I could do. And selfishly, despite his pain, I wanted to keep him around as long as possible. Although it was expected, I was still surprised and even unprepared when Pop died at the age of 84. I still miss him, but his death came with an important lesson. Losing him as I did, feeling helpless in the face of his suffering and his clear desire to pass, forced me to reconsider my long-standing and adamant opposition to the Medical Aid in Dying Act. A proposed bill to allow medical aid in dying in New York would enable terminally ill, mentally capable adults with 6 months or less left to live to request a prescription from their doctor for medication they can take to die peacefully and on their own timetable. New Jersey and Vermont are among 10 states, along with Washington, D.C., where medical aid in dying is authorized. In 2018, my first legislative session as an assemblyman, I encountered advocates for the Medical Aid in Dying Act. I always brushed them off. As a pastor and church leader, I was adamantly, to my core, opposed to this legislation. This continued until not long after Pop passed. I happened to encounter one of the Medical Aid in Dying advocates in the state capitol complex hallways, and she told me her story about losing a loved one. "All I wanted to do was stop the hurt," she said. At that moment, I was back with Pop, helpless to stop his hurt. And I finally realized what a gift empowering a terminally ill individual and their loved ones with the ability to manage their final moments in peace and on their own terms can be. As a man of deeply held faith, I believe that life is sacred, and we should do everything possible to prolong it. I am concerned about the recent trend of increased suicide rates in my community and around the state, particularly among young people. But medical aid in dying is not suicide, assisted suicide, or euthanasia. It is about stopping the hurt for someone who is facing down unthinkable pain. It is about providing them with the grace to decide, in counsel with medical and mental health professionals, their family, and friends, that because of their incurable and irreversible disease or condition, they've suffered enough. So complete is my conversion that I not only support medical aid in dying, but I also signed on to co-sponsor the bill that would make it legal in New York. That bill has strong safeguards to prevent abuse, but it's also worth noting that in more than 25 years since Oregon became the first state to approve medical aid in dying, there has never been a single substantiated claim of any abuse in any state where it's authorized. Not one. To be clear, I am not challenging religious doctrine about medical aid in dying. I am merely saying that as a man of faith, I see the value in providing individuals who are suffering with the option to, within strict parameters, choose to free themselves from pain. If I'm wrong about this, that will be between me and my Maker. I strongly believe that my job as an assemblyman, a minister, and an activist is to keep an open mind. I am constantly learning new things, and that knowledge and experience helps me help my constituents. I wish I hadn't taken losing Pop the way I did for me to learn this hard lesson. I ask all New Yorkers, particularly my colleagues in Albany, to take another look at this legislation. Please believe your eyes and ears and listen to your heart. Learn from my experience. Don't wait till it's your parent, spouse, or loved one. It's time for New York to pass the Medical Aid in Dying Act. So why medical aid in dying? I think probably post this presentation, hearing from Assemblywoman Paulin, hearing from Dr. Carpenter, Reverend Assemblymember Al Taylor, and myself, it's clear why medical aid in dying. It's because it's an option. It's a tool in a toolbox for physicians. It is not something that everyone uses. I think the best analogy that I have heard about this, and I say it often, is that not everyone eats meat on Fridays. Some folks observe Lent. They don't eat meat on Fridays. McDonald's still sells hamburgers on Fridays. No one is prohibited because of someone else's beliefs to do something. If you don't want to use medical aid in dying, if you don't believe in it, if it is not something that you want to have a conversation about, you don't need to. It is about an individual having an option when they are facing down a terminal illness. And why now? Because as I said when I was speaking before, we have lost 25 advocates in the course of the last 9 years. Those are the folks that were in the room, that we knew, that we had conversations with, that were walking the halls of Albany. There are thousands more across the state. We're hearing stories all the time about folks wishing that this was an option for them. Folks like Al Taylor, who wished that he advocated for this long before his father's passing. It's because we know suffering, we've seen suffering, and we know how to fix it. When Governor Jerry Brown received the California law to his desk, we didn't know if he was going to sign it or not, but he did, and what he said in his signing statement was, "I do not know what I would do if I were dying in prolonged and excruciating pain. I'm certain, however, that it would be a comfort to be able to consider the options afforded by this bill, and I would not deny that right to others." And that's all that advocates for the Medical Aid in Dying Act are asking for, is that there is an option, they're able to use it. If others don't, that's okay.
Thank you, ma'am. And finally, we're ending the presentation, and then it will be followed by Q&A with a personal story by Rena Schwartzbeck about her and her mother. And I want to remind everyone again, questions will be asked at the end. Please don't ask them in the middle of someone's presentation.
My mother, Lillian Gewurtzman, My mother, Lillian Gewurtzman, died March 2nd of this year. She was a Holocaust survivor. She survived Hitler, Stalin, diphtheria, a displaced persons camp, the loss of her husband of 58 years, and one cancer. But the second cancer, a very rare angiosarcoma, resulting from the radiation treatment to treat the first cancer, proved to be too much for her. Initially small, then fist-sized external lesions began to appear on her chest. They would ooze through her bandages and then through her pajamas. She had a mastectomy as a Hail Mary attempt to remove the lesions on her chest. But a month later, there were new growths. The cancer was extremely fast-spreading, and there were no more treatment options. She was starting to lose weight. She couldn't eat, she couldn't sleep well, she was exhausted, and she complained of continuing burning pain. Like many people, my mother believed the pain medication she would provide it on hospice would eliminate her pain. But the morphine and then the fentanyl patches were no longer enough. She remained in constant chronic pain. The pain meds were also accompanied by their own problems: hallucinations, constipation, stomach pain, nausea, and increasing the opiates meant she couldn't fully retain her faculties. She was reluctant to relinquish the one thing she still had some control over, her wonderful mind. My mother spoke 5 languages. She was an avid reader, cultural Renaissance woman. She was a loving mother, grandmother, aunt, and was central to our family. She was a strong woman, but her suffering in her last weeks was horrendous, and she became desperate. As the lemon-sized lesions spread to her sides, my mother looked up with terror and asked, "What happens to me when they spread to my back? I won't have any way to lie down." And I could say nothing. At 88 years old, she told us she was tired of fighting. She had survived enough, and begged me and my physician brother to help her die. As I started to research what was possible, she got angry at the legal limitations. "Why can't you help me? Do the right thing." I looked into moving to Vermont, where medical aid in dying is allowed, and establishing a relationship with a physician willing to prescribe was unrealistic. Hospice said, hey, there's another way. Great. She can stop eating and drinking. I thought, it's 2023, we have all this technology, and the only choice I have is to watch my mother starve to death. Hospice could only offer more morphine, but my mother didn't want more morphine. Most children feel a combined sense of duty and love when advocating for a dying parent. But children of Holocaust survivors are on a mission to prevent any more suffering for their parents. Watching my mother suffering up close and experiencing the helplessness I felt, anyone would want to grant their loved one's last wishes. She was desperate and afraid, and I had to say no to the one thing she most wanted. The memory of my mother's last moments could have been so different. She wanted her children and grandchildren to visit and end on her own terms. She likely would have done so maybe a week before she passed. Instead, her last week included a stroke, pain, nausea, 3 days of gurgling breathing until she took her last breath. It exhausted and traumatized her family. But primarily and most importantly, the experience was traumatic to my mother. As a psychologist with a specialty in trauma, I have learned that one of the hardest things for people to cope with is a sense of helplessness and lack of control. When someone is terminally ill, how they die may be the one thing they can have some control over. But that autonomy does not yet exist in New York. It was a demoralizing, hopeless situation. And to what end? She had no chance of recovery, so for whose benefit was her suffering? If I'm honest, the following thought played out in my mind. Do I love my mother enough to risk going to jail? Do I love her enough to end her pain? Maybe if I didn't have kids and a husband, I would have risked it. I couldn't do it. My mother hung on for another 48 hours, laboring more and more to breathe until she was gone. I sat with her in her bed, holding her hand. I apologized repeatedly for not being able to grant her the wish to die on her own terms. I vowed to advocate for compassion and dignity in dying for others in her honor. Thank you.
I'm going to start with a very short one addressed to Amy Pollan, which was, how might the New York Health Act impact this issue?
Impact what?
How might would the New York Health Act
It
impact
wouldn't
this issue?
impact it. Easy answer.
Thank you. It's on. Thank you. I would ask about slippery slope arguments. It seems like that's probably something you have to deal with a lot. And of course, there have been many of those in history when women were going to give the right to vote, and so there were all these concerns. Oh, if we do that, they'll neglect their kids, and so on and so forth. I'm happy that some of our Pollan. But on this issue, I hear often about if we pass this, then 5 years from now, it's going to be like Canada and the Netherlands, and there are probably rumors now that in the Netherlands, if somebody breaks up with their boyfriend or girlfriend, they can easily access medical aid to die. So how do you deal with all these slippery slope arguments about, yeah, if you do this now, down the road, God knows what you're going to be asked to approve?
I think that's aimed at me. Having passed many, many, many bills, I can tell you the one thing I have learned is that once an issue is done, it's done. It's very, very traditional in the legislature to think you've solved the problem even though you haven't. So with something like this, I can tell you that it's not getting opened up again. The experience in Oregon, they haven't opened it up again, and that's the kind of state that might. New York is not opening it up again. So this is it. The bill as it's drafted is what we expect to pass and what we would expect to be law. The only thing that we've changed since we've introduced it is to make it even harder for someone to get this medication. The safeguards have gotten even safer. So it's not going the other way.
Thank you. Here's another question on a note card. Might it be a concern that with healthcare being increasingly run so much on a profit model, doctors might be coerced by the businesses that run many of their practices or by the health insurance companies to help a patient die who is costing them money?
Well, let's just say first that patients don't cost me money. I actually make more money if they are alive and I can continue taking care of them. And this is something that somebody individually has to come and ask for. It's not something that's decided by insurance. It's not something that's decided by a hospital or by a doctor. This is an individual coming forward to make that choice for themselves. So, no, that is not a concern.
Hello, thank you for your words, and I'll just have more space. So I'm a Catholic priest from St. Peter's Church here in Riverdale, and we have about 90% of our population is Hispanic. So as a minority, they're kind of concerned. They feel like they're going to be like pushed towards making this kind of decision. I was talking to even a young girl recently who was like suffering mental health issues, and she's like, I don't want to say anything because then it gets legalized, like I know in other countries. Now they're kind of pushing people with mental health, and so there's this fear. And I'm going to be fully transparent. I am against the bill. I understand your compassion, and I really I believe that we do hold in common this principle that human beings have innate dignity. But the way in which we then apply that, I think, is different. And I am concerned about the slippery slope arguments. I think there's like an internal logic when you say some people are better off dead, then that waste paper basket gets expanded and more people get added to that category. So that has been borne out in the Netherlands, 12 years after euthanasia was first allowed for those who were voluntarily choosing it. 12 years later, now infants who were considered, too disabled for their life to be worth living, the parents were able to make the decision for them. In Canada, I understand you have a lot of safeguards here, but Senator, you did mention we may have expansions coming down the road. So that, I think, is true, right? And this is what we see in Canada. Next year in March, they're going to permit those who have mental health issues to choose assisted suicide. And so really, I think the House of Lords in England, when they made a statement, they said the prohibition of intentional killing is the cornerstone of law and social relationships that protects each one of us impartially, embodying the belief that we are all equal. And so we have this foundational dignity that we all have in common. And as soon as we start saying some of you are better off dead, then it's a slippery slope is inevitable. I mean, we may not want it. I believe you don't want it, but it's just going to happen over time.
What's the question?
So my question is, do we want to live in a society like this, where some people are considered better off dead?
Anyone want to take that on?
Sure. Firstly, because it's self-determined and self-administered, it's the person's choice. It's not society's choice. That's number one. As far as the concern that somehow more vulnerable, poorer populations, immigrants are going to be disproportionately impacted by this or use this more, in fact, the opposite has been true in all of the states. It's unfortunate, but it's always the more affluent that gets access to it. It's the more, it's almost rarely just like all of healthcare, do we see, unfortunately, more vulnerable populations getting access. So it's the opposite, and you can assure your constituents of that. Number three, I don't believe, and if I did, I want to correct my earlier statement. I don't believe this is going to be at all a slippery slope. We can barely pass this with added safeguards, and all of the laws around the country are nearly identical. So we're not the Netherlands, we're not Canada. They have lots of things on their books that we'll never see here in the United States, and an expansion of this is likely one of them. Thank you.
This card has two questions.
Hold on one second. I also just want to add, there's an interesting phenomenon in states that have passed medical aid in dying, which is that they see a much higher introduction of people going on to hospice care. That passing these laws opens up people's minds and opens up their ability to talk about death and accept death, and so they're going on hospice. It's not necessarily that they're all choosing to end their lives. It's actually improving, and there's the largest group that does not access hospice care are people of low socioeconomic groups. So this actually will help.
No, I'm sorry, I interrupted. The next card has two questions that pertain to safeguards on either side of this, either end of this issue. The first is, our healthcare system is full of disparities which manifests in access to care. In the case of low-income and/or disabled people at the end of their lives, Medicaid will pay for hospice care. For people who are just above low income or who are middle income with spotty insurance, there can be a heavy familial burden in caring for a family member at home because insurance does not pay for enough of the care required. The issue here is the need for a New York Health Act, but the reality is that there may be pressure on a patient to end their life because they feel the weight of their illness on their family. How to guard against or deal with this, and how have other states dealt with this?
So I'll just go first just because I worked to pass the law in New Jersey, and obviously now we're here in New York. The reality of this conversation around low income is actually, you know, as the Assembly member just said, they are generally folks who don't access health care to begin with. Medical aid in dying is generally not an option that the state pays for. If you are on state Medicaid, Medicaid dollars do not pay for medical aid in dying the way that the law is written. It's not, the state is not fiscally responsible for it. So the thought that folks would be pushed to use medical aid in dying because they don't have good health insurance or they're on Medicaid is just false. They would have to pay themselves for the medication, and it can be costly. When the law passed in California, the price of the medications that are generally used went up. It can be anywhere from $1,000 or more. So folks that are in the low income bracket generally can't afford to get it, unfortunately. That's the reality.
I also want to remind people that the safeguards that we put in, one of them is to get a second opinion. So that would also be an out-of-pocket expense that would be, I don't know how many of you pay your own health bills, but you know, doctors aren't cheap. So we, and cancer doctors in particular. So, and that's really where we're seeing this use. So I think, again, it's unfortunately the opposite. Poor people will have much less impact, and vulnerable people will have much less impact or opportunity to avail themselves of this bill.
So the other end, the other end of this is the second part. If I realize that dementia is overtaking me and I have the wherewithal to end my life before that fully happens, that probably would not fall within the 6-month timeline stipulated by this law. How to deal with that? How have other states dealt with that?
So to be 100% clear, anyone with dementia or Alzheimer's as a diagnosis would not qualify for medical aid in dying. You have to have the mental capacity to make a decision. So anyone with that diagnosis would not qualify. Dementia and Alzheimer's, although horrible, are not terminally ill diseases. So those patients would not qualify. If you had a terminal illness and Alzheimer's, because you do not have mental capacity, you cannot ask for medical aid in dying. You can, but you will be denied. The other thing is to deal with dementia or Alzheimer's, there's a thing called the dementia provision that David Levin worked really hard on. that folks can fill out prior to a diagnosis to do your wishes, as we were talking about in the beginning, prevention. That's really important, but this bill does not apply to folks with those diagnoses.
Question, I have a question. I just want to be clear, I work in a federally qualified health center, and to say that, well, this medicine is too expensive and wouldn't get covered by Medicaid anyway, for me, that's not fair. I mean, you're cutting my patients out of this whole story. And access to care is part of what this is about. And I think that's what the New York Health Act question was about too, was everybody would have access to their, excuse me, healthcare provider. So just that. And is this physicians only? Would nurse practitioners or PAs be allowed to participate in this?
The bill as it stands says that physicians, medical doctors only can prescribe.
Not that all of them have.
Well, that was actually my question. It was sort of an access question. My name is Daniel Kogan. I've been a hospice and palliative care nurse practitioner for over 20 years. I have tremendous respect for everybody's work. And yeah, my question, I can understand reluctance to tinker with the bill now, but I do wonder if there's any thought to expanding for certifying and prescribing to nurse practitioners, physician assistants.
So,
in my mind, there's always an opportunity to expand scope, because we know that, within your scope, for example, you would be very capable and you're not able to practice to the extent of your license, right? But I don't think it's something that we can open up. It's not something that the other states have done, and it's hard enough like it is.
3 jurisdictions allow it.
Do they? Yeah, well, we can look at it, but we've been very cautious about being as tight and restrictive as possible in order to get the bill over the top.
Ma'am?
Someone could bring him the mic, but I'm going to do the next one. Given the public support throughout the state, what or who are the remaining obstacles?
You want to take it? Well, I went to Lobby Day for the New York State Academy of Family Practice back in the spring, and went from door to door talking to assembly and senators. And there are a few. I think the religious issues are huge. There was one senator who said, hey, I want this. My wife wants this. She's a nurse. But I can't vote for this because of my jurisdiction and my religion. Which I thought was, just not the right answer. And then I had somebody else who, on a Zoom call talking about it, said, well, you know what? Isn't pain just a part of death? Like, isn't that just what we need to go through? So there's just education, 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 and having, the constituents sort of let them know that they really want their legislators to pass this bill.
So I believe that the obstacles are many fewer than they've been. We're making enormous progress. We have enough votes to pass the bill now. I'm talking about the Assembly. The Senate, I'm less certain about. So if you have a senator, I would ask them to get on the bill on their side. But on the Assembly side, I believe that we're going to be fine this session. I've said that before. But I really believe it this time, and I believe we're going to see movement in my house.
I want to thank you. I am on the opposite side of the issue, but and I do agree with Father that I think we all care. We all concerned. We all have had loved ones. My mom died of Lewy body disease. That's not an easy disease, okay? But at the same time, I'm a teacher, I'm an educator, and I listen for code words and buzzwords, and I look for parallels in history, and the question is coming about pressure. That's what I want to ask. But I want to just give this little intro. Teachers, just shut me up, because teachers, we go on. But we've heard choice before. We heard choice during the time of slavery. We heard choice during the time of the legalization of abortion. Now we're hearing the word choice again when it comes to this. With the arguments, you don't have to have one. You don't have to do this, but you can't push your ideas. And I'm not even coming from a religious perspective necessarily. And the idea that, and even the changing of words, well, this is not suicide. That's a euphemism. It is. I'm giving you, I'm giving you a gun to help kill yourself. In this case, I'm just giving you a pill, but we're not going to call it what the reality is, because truth is reality. If I like it or don't like it, it is what it is. So my point is this. It's always progressed more, okay? I've had friends who have had abortions. There's free choice, but it wasn't their free choice, right? And it's not that issue, I get it, but I'm trying to connect the dots. That it was taught at the beginning, women's choice, and yet many women, and I've experienced this.
Do you have a question?
Yeah, oh yes, I know, we don't like connections, I know. But it's kind of connected to this, that eventually people will be pressured to do what was one point a choice. For a lot of people will become a duty to choose. And we're seeing this all over the place. And what would make us think that this is not going to happen with this? There's no guarantee. When you take those pills home, who's going to take it? Who's going to shove it down their throats? Who's going to do this? How are they going to feel like a burden? That, they're not even tell their family, right? And so who's going to prevent the pressure at home? That's my ultimate question.
Good. Thank you.
Thank you. Thank you.
So as the assembly member said in the beginning, to your point, who's going to prevent pressure at home? Well, one of the amendments that we made to the bill this year requires that both witnesses to the member's request for the medication, because it has to be requested both written and orally to the physician, two doctors as well, both witnesses cannot benefit from the member's estate. That's a strong safeguard that originally it was one witness. We've changed that to two to ensure that. So there are a lot of independent folks involved in the process, including the patient's two doctors that they have to find to make sure that a patient's not being coerced into this. The other part that we didn't mention is that when a patient asks for medical aid in dying, they also are counseled on all of their other end-of-life options: hospice, palliative care, palliative sedation, voluntarily stopping eating and drinking, continuing treatment. Any options that are on the table for the patient must be explained to them. That is also written into the law. 90% of people who use medical aid in dying are also receiving hospice care. They're at home. There's nurses, social workers, people in and out of the house all the time, making sure that the patient is acting of their own volition.
I also want to address the issue that you mentioned, that this is suicide. It's not suicide. When you had patients,
It is.
when you have people who are, let me finish talking.
Excuse me, I'm going to interrupt. We're not having a dialogue once the question's being answered. People have a chance to ask a question, and our panelists have to be free to answer. We can't get into arguments. We're getting information back and forth.
During 9/11, when patients were on the Twin Towers, there were many of them who realized what was happening, and they decided to jump. They did not want to burn and fall. They wanted to jump. And the insurance companies looked at that and said, that was not suicide. You were not jumping. You knew you were dying. There was no way. And that's the same thing with this. It's not suicide because you are dying. We know that you're going to die, and it's how you want to die. It's making a choice about what you're going to do. And that is very different than a violent, and generally suicide is something people do alone and not with the support of their family and friends. So it is extremely different.
We'll agree to disagree.
Okay. Please, if you want to speak, raise your hand, and someone will bring a mic, but we're alternating. Some of these are a little bit over the same material. I'm trying to avoid those. A terminal diagnosis can often be inaccurate. How will you determine terminal, since terminal can be misdiagnosed?
I think we lost our battery.
That is, again, going to the point of when people actually ask for this, you need two doctors to say that they have a terminal diagnosis, which is less than 6 months. And you also have people who do not actually take it. They just want this to be available, and they take it at the end of their life. This is not somebody walking around, just gets diagnosed with breast cancer and goes, that's it, I'm just gonna go get this and I'm gonna end my life. This is not that situation. So it is, it's not necessary.
The other thing I'll add to that is that a patient, it says in the bill it has to be incurable, irreversible, because there were concerns that if someone had diabetes and stopped taking their medication, well, then they could have a terminal illness, because that could lead to death. So this bill specifically states incurable, irreversible, 6 months or less left to live.
You said that it's looking promising in the House, but what about in the Senate? Where does Andrea Stewart-Cousins, who was where does she stand?
She stands like she needs to hear from you.
While you look at that side.
In the Senate, we're working really hard. There are a number of co-sponsors on that side as well. We have put just as much energy into both sides, but I would say leadership, hearing from their constituents and hearing from the community that this is important. All politics is local at the end of the day.
This one, I'm putting two together. I hope one isn't too intrusive, so don't answer if it is. To Dr. Carpenter, why was your father not getting pain medication in hospice? And related to that, I think, is if Calvary Hospital in the Bronx, which is primarily a hospice, can ensure patients don't die with excruciating pain, why can't other doctors ensure the same relief?
I'm going to give it to Dr. Carpenter to answer, but first I'm going to say, calling out Calvary is a buzzword for me, because we had an advocate, Jay Callio, who was a 9/11 first responder. There's videos on Compassion Choice's website where he was screaming in pain because Calvary could not stop his pain. It is totally inaccurate to say that any doctor could ever take care of any and all pain.
My mother was in hospice, and as you heard from my presentation, not just pain, but I had thought, wow, morphine, fentanyl, that she'll be fine. Well, huge side effects to these things. So, and pain. So, it's a misconception that I'd had before I watched my mother as well.
My father was not in pain. My father was weak. He could not walk. Towards the end, he had a hard time, being able to express himself, and he knew he was, his breathing, that it's not always just pain, it's the indignity of those last few days of life that for him, he did not want to go through. And I think that's important for people to realize that it's not just suffering in the sense of physical pain, it's also the indignities of the last few days.
This was a long time ago, but my mother was in West Palm Beach Hospice. Was in West Palm Beach Hospice. And I remember what the hospice minister said to me was this life and this quality of life. And at this point, her life had no quality. And unfortunately, I just dealt with it less than 2 months ago with my husband in Columbia Presbyterian. And we had to make a decision. He would have been on a ventilator his entire life, what to do. And Columbia Presbyterian took away the BiPAP and gave him pain medication. And my sons were there, and so was I. And we were there until the end, but it was the only humane thing to do. So I definitely believe in everything you guys are saying, although I was late. But I think the main thing is what the minister said. There's quality of life, and at certain points, people that are dying have no quality.
This one, I think, perhaps is not factually accurate, so you might respond to that. The American Medical Association recently reaffirmed its opposition to doctor-assisted suicide. What makes this panel think they know better than the AMA?
Only about a quarter of physicians actually belong to the AMA. It's really a lobbying organization. Does not speak for all doctors, I would say. And the same thing when it comes to a lot of the hospice, the American Academy of Hospice and Palliative Care, and the HIPCANI in New York. Because there are so many hospices that are religiously affiliated, they have often just passed on not supporting, but not going against. So they kind of just are like, we're not going to say anything.
There was also a survey done in New York State that showed that physician support for medical aid in dying is 67%, with only 19% of physicians opposed to the issue. So although the AMA, as Dr. Carpenter said, might at the top level say that they're opposed, they don't have very many physicians involved. And physicians on the ground, like the New York State Academy of Family Physicians who are treating patients, also endorse this.
I'd just like to make a few comments. I'm David Levin from End of Life Choices in New York, and I've been working on this issue for a very long time, studying it for the past 20 years. And I want to make respond a little bit to the comment that you made, the teacher, about the possible duty to die that people might feel. There's just no evidence of that. We now have about 100 years of cumulative evidence from states which authorize medical aid in dying, and there's no evidence whatsoever that people are feeling a duty to die at the end of their lives. People are suffering, and that's the only reason why people choose this. They want to continue to live, but they can't, which is another reason why it's not assisted suicide. If you think about people who die by suicide, they could continue to live, but they choose not to. People with medical aid who choose medical aid in dying are dying, and they're going to die very soon. It's only a question as to how they're going to die. And they make this choice again in consultation with loved ones and doctors. There are always at least 4 or 5 people who must be involved, including the 2 doctors, 2 witnesses, almost always family members, and almost always with family support. These are not people who are suffering from a mental illness, as most people who die by suicide are. These are people who are dying and are going to die very soon, and the only question is, are they going to die with a lot of suffering or not? The second point I want to make is that, again, with respect to duty to die and otherwise, this option is used very rarely. It's only about 4 of 1,000 people who die in states that authorize medical aid in dying who die by that means. Why? Because people, for the most part, have a very strong will to live, including those who die by medical aid in dying. Over 90% of those who die by medical aid in dying are actually receiving hospice. They're getting the best possible end-of-life care, and yet it's not enough to reduce their suffering sufficiently. The last point I'm going to make is about the slippery slope. Again, there is no evidence of that in this country. It's true that things have changed in the Netherlands and Canada, and they've gone way beyond, I think, where we can ever go. If you think about it, only 10 states now and D.C. have medical aid and dying laws. As Assemblymember Paulin said, it's very difficult to get these laws enacted to begin with. And so there's hardly any chance that there's room for expansion. And if you think about it, how is it going to happen? It has to happen by legislatures. It's not going to happen in New York State, I don't think, and any other legislature either. And otherwise it could happen by litigation. I know the court process. No state has authorized medical aid in dying through the litigation process except for Montana, and that was not because it was a constitutional right that they declared, but only because of their own statute, which permitted medical aid in dying beforehand. So I think there's a very, very small chance of any expansion or any slippery slope in this country. We have our own cultural, religious, and healthcare history, which is so much different than other countries.
Great, thank you very much. We had a question over here.
Yeah. Okay, we'll do one more, but we want to end promptly at 2,
Okay.
so this will be the last.
All right, so this is a question for Congresswoman, or Assemblywoman. Okay, number 1, so it has to do with wording. You had in the bill a wording that was supposed to be a safeguard that the individual themselves may ingest. You had the term may. Why wasn't the term must? Because I have a concern. I have a concern that the longer you keep this medicine around, okay, that the patient decides not to take it, there are a lot of teenagers and there's a lot of children that are inadvertently exposed to it and accidentally or purposely can take it, especially for teenagers with the state of their maturity not having reached the height and their intense relationship with a grandmother or a grandfather that's dying, or anyone that's dying.
So I'll say the reason the may is used is because they may not. But the only way that the medication can be taken is to have been to be self-administered.
But may indicates that if somebody.
No, but it's a must when
it's
an absolute must shall in terms of the way.
English shall is.
But we don't want to force someone who doesn't want to do it. That's the balance,
But
right?
I don't want somebody else to give them it.
No,
even
I
though it's
completely
opposed to
agree.
your
And there's
language.
another provision that I didn't mention
Okay.
in terms of disposal and safeguarding
No,
the
you did
medication.
about disposal.
Yeah.
I'm talking about with persons alive, because when they get the medication, they're not going to use it right away, or they don't have to use it right away. So that means, and we know right now that teenagers will take other medications that parents have and sell them on the street.
How do you safeguard for, family members
Right.
not getting access to it? Maggie, you must, or people in other states, how have
Yeah,
they?
I can explain the process, and then Dr. Carpenter, if you. So right now, the way that the medication is taken first, it's a whole entire process, right? The beginning of the day, the person cannot have anything to eat or drink. It has to be taken on an empty stomach. They have to take a drug that prohibits them from having nausea, so like a Zofran or something like that, followed by an absorption medication that helps the medication go through their bloodstream quicker. And then it is a composition of different types of medication like a morphine or diazepam. It's basically an overdose of those things that are in a compound that have to be mixed inside of a liquid, and the person has to drink it, or if they have a feeding tube, put it in their feeding tube, but it's not pills that are out.
So how can you make sure that it's the patient who takes this and other people in the family don't get their hands on it? I think safety issues, right?
Okay, I'm sorry, but I have to say that, so we have guns in people's houses, we have teenagers driving cars, this is obviously something that needs to be prepared. Anybody who is going to get it is going to be very careful with their medications, not throwing it around for a teenager or somebody who is young to take. I mean, a kid right now could go take their morphine and overdose, and that is happening.
Right.
No one's saying anything about that. This is a very different situation.
But there's no law.
No, but wait.
This isn't a law that is going to be putting dangerous medications in lots and lots of households. If we're going to talk about what ifs, we will never get anything done.
Excuse me, if I could just ask, has there ever been an
my next
accidental
question,
There's
ingestion of these medications?
No, there's never been an accident. And what I'll say is this, the way things currently stand with hospice, don't know if you've ever had an experience, but hospice comes to your home when the person gets it, and they drop off a literal toolbox, because I've been through this with several family members, that has all sorts of medications, including morphine tubes, pre-filled morphine syringes, and they say, you got to give one every 2 hours to the person. If you give too much, they might die. If you don't give enough, they're going to be in pain. What happens right now is much scarier than what this law would allow.